And as we get started, I want to thank our ECHO partners, the CareQuest Institute for Oral Health, UNLV, and the Oral Health Progress and Equity Network. Next slide, please. So in the vein of flexibility and that expression, we make plans and God laughs, if any of you have heard that expression, we have a slight change in our agenda for today. Our didactic presenter had an unavoidable emergency to take care of at the top of the hour, so won't be able to join us until about 15 minutes in. That has required us to flip our sessions, our discussion topics today, where we're going to start off with a case discussion and then have the didactic presentation in the second half of the call. Just to keep you on your toes even further, this month's case discussion is actually not going to be presented by an external presenter, but it's going to be a discussion that Annalise, Executive Director of AIDPH, is going to be leading us in for you all to consider the realm of rural LGBTQ plus oral health and challenges and approaches that we need to address as a field. Next slide. So as I shared, today's call is being recorded. We're going to ask everyone to please type your email and organization in the chat so we capture that through the recording. Slides, forms, and any materials referenced today will be available following the call on the AIDPH website. We remind you to avoid sharing any personal health information on this ECHO session. And if you have any questions about Zoom during the call, please chat with Annalise Cothran in the chat box. So about AIDPH, I think most folks have been here before for previous ECHO sessions, so I won't read this slide. But to say that AIDPH is a 501c3 nonprofit with a focus on centering health equity as a cornerstone of oral health education and training. And we encourage you to visit the website to learn more. Next slide. For those who haven't been here before, AIDPH's Rural Oral Health ECHO follows the CareQuest Institute's 3 domains framework using the lens of rurality and health equity. These include teleprevention, minimally invasive care, and integrated and personalized care. And the model has participants taking knowledge back to their communities to implement in their daily work, building the capacity of the oral health professional workforce. Next slide. This month's topic, as you know, is LGBTQIA plus rural oral health. Next month's topic will be personalized and predictive care. And to see this slide one more time, if you want to come back and visit the information, this is also available on our website. Our session norms are here on the screen. One I'll highlight is please introduce yourself with your name, organization, and location before speaking. We ask that you keep your video on, but keep yourself on mute. And of course, to respect one another and respect patient health information. Okay, with that, actually, we're going to pause this screen and I'm going to turn it over to Annalise, who's going to share some other slides with all of you.
Yes, actually, I'm gonna offer a couple things. So we're just being very transparent in that the goal was to have our didactic presenter do some level setting before we enter discussion today. And so since we're flipping things around, my goal here today is first to name that I am not an LGBTQIA plus identified person, meaning I don't have the lived experience. And so I'm here to help facilitate discussion and to listen. That is my goal as a cisgender straight person, is to listen and figure out ways that I can be an advocate or an amplifier. So I'm not super, I wish this was not sort of how the discussion was going today, where I was giving the context, but that's where we find ourselves. And so in order to do that, for us to effectively engage in discussion, I wanted to level set to begin with, if that's okay with the group, because I recognize that as it relates to LGBTQIA oral health, or just even the queer community in general, that a lot of times people may not effectively engage because they don't know the language, because they don't have the terminology, because they don't understand the context. And I have found that oral health professionals in general feel hesitant to engage in the topic because they may not have the right language, or they're so worried about offending and really want to be cognizant and mindful moving forward with empathy on how to use terminology and language, et cetera. So I thought that just might be a good place for us to start, is talking through some level setting and terminology. And the first thing that I will invite people to do in that vein is to ensure that your pronouns are part of your Zoom name. The easy way to do that is just to hover over your box on the screen. There's 3 dots in the top right corner. And if you press those dots, you should be able to rename yourself. And the reason why we add pronouns is that is really a cornerstone best practice in terms of supporting the LGBTQ plus community, and particularly those who are gender nonconforming, is a way to create space for people to authentically express who they are. And I like to tell this story because I hear in our community too, and it tends to be a small community. I know everybody here, they already know who I am. We don't need to share pronouns. And I've had oral health professionals in my professional community change their pronouns. And giving space to them to do that is really important. So that's best practice number 1. And as part of our session norms, I'll just invite us to carry that over. Briefly, I'd like to share my screen and talk a little bit more about sort of this whole space around LGBTQIA terminology. And I like to share the genderbread person because it's a really great graphic and a good conceptualization of the differences between gender identity, gender expression, attraction, and sex. And so I'm not going to go through all of this here today. I would invite you to sort of look this up and just Google the genderbread person. I think this is on 4.0. So there are a few different versions as the language evolves and we have more context to be able to talk through what gender identity, expression, et cetera, means. So I first, just from a level setting perspective, want to talk about gender identity and attraction, because those seem to be a place where we have a lot of ability to confuse them if you haven't been sort of keeping up with what is the differences in the LGBTQ terminology and what all of those different letters mean. Perhaps that's the best place to start. And the number one thing is gender identity. So gender identity is actually a biological process that occurs in our brains, and everybody goes through a gender affirmation process developmentally. So whenever I went through my gender affirmation process, what I was assumed at birth, which is female or woman, that matches with my brain and my biology and how I identify as myself. For gender nonconforming people, whatever they were assumed at birth, as they went through that developmental biological process of affirming their gender, their identity was different than what they were assumed at birth. And so we like to talk about that as the transgender community, or gender nonconforming community as the broader umbrella under which many different expressions and identities may be actualized. Attraction is not part of identity. It's very separate. And that's, who we find ourselves feeling attracted to and drawn to. And the reason why it's important to kind of give this context about gender identity, which is our biological process, expression, which is how we present ourselves to the world, and then our attractions, is because as a provider, this is part of your patient or the person in front of you. This is part of their entire lived experience. And how you are creating a patient care experience should really have the full context of all of this. Sex is also a big piece of it. I know I work with providers who talk about needing to treat the biological components of a patient and having really important and nuanced and sensitive conversations around all 4 parts of this. Okay. So I'm going to stop sharing my screen and I'm going to invite Jasmine to share the slides again, if that's okay. And we're going to get into discussion as best as we can, recognizing that we can still ask questions along the way, recognizing that there's a space for us to kind of authentically engage in the material, which was AIDPH as an organization has taken a deep dive into LGBTQ oral health equity. It has really been a hallmark of our programming since 2019. And the reason why is because whenever we did our gap analysis for our organization, we realized that nobody was really investing in this space, that there is just simply not enough research, there are not enough resources. And consistently, what we've heard back from our community through surveys and other types of engagement is we need more. I really hear a lot from providers, kind of what I shared earlier, which is we want to know what to do. We want inclusive language. We want to understand educational approaches. We want to understand scientific and programming approaches, but there just isn't enough out there for us to base our information on. And I think we also have to recognize our roles within this, right? So as cisgender people or as straight people, how are we leading or how are we putting seats at the table? How are we engaging with this community and not being paternalistic, being very authentic? And so the goal was to have a discussion here with how AIDPH should be approaching research design and programming for this issue that we've had an authentic investment in, but not as much as it relates to rural oral health specifically. So in the chat, I'm going to place a paper, which Zil Joyce should probably recognize. And this is from NRHA on LGBTQIA health in rural America. And it was a really fantastic policy brief around how to support rural communities and their healthcare as it relates to LGBTQ plus people. And so what struck me as the takeaway from this policy paper was that, and I'll just briefly read what's on the screen, LGBTQ plus individuals face the same challenges as many other rural Americans, but these inequities can be exacerbated because of limited choices in healthcare services, closer social networks, and concerted efforts to improve healthcare workforce, and also that intersection of discrimination and not having inclusive policies. Next slide, please. And so in that vein, AIDPH wanted group feedback and discussion to figure out how we need to be considering and addressing specifically from a non-clinical perspective. So social determinants, programming, research, et cetera. How can we do a better job supporting LGBTQ rural oral health? And what are the research perspectives that the community needs? What are the gaps that we should be filling and how should we be filling them? And then most importantly, who should we be partnering with and who should we ensure has a seat at the table as we make authentic investments in this area? So that was the goal, was to get feedback from this think tank on how we can pursue this equitably and authentically as an organization. So Stacy, I'll turn it back over to you for facilitation.
Okay, great. So I'm just in real time here looking at how many folks we have on the line right now. So we have 32, and I think 1, 2, 3, 4, 5 of us are staff, give or take. So it's feeling like we might want to go into 3 breakout rooms. Does that feel right to you, Annalise?
That's great. So I guess we can open 2 breakout rooms and 1 group will stay in the main session.
Right. So for folks here, further transparency, we figure out how many breakout rooms we need based on how many people show up, which isn't always aligned with how many people register. So that's where we are. So we're going to go into, I'm looking at the clock. I think we're going to have about 10 minutes to go into our breakout rooms. And the questions which we're going to copy and paste into the chat are where are the gaps in non-clinical programs and services that support LGBTQ plus rural oral health? What research should we invest in for this community to address the gaps? And who should AIDPH be partnering with to design programs and research? So I will ask Annalise if you could copy those and paste them in the chat, so folks will have them when they go into their rooms. So we'll spend about 10 minutes in our rooms, then we'll come back and ask for folks to share any highlights of their discussions. And then we're hopeful that our didactic presenter will be with us. So I think we're good for the breakout.
See, I'm sorry, I wanted to signal you may not be able to see it. So Caroline asked a clarifying question, which is, how are we defining not clinical services? And I'm happy to say, essentially, like, not walking into a dental clinic and thinking about what the oral manifestations of LGBTQ types of clinical care, that's not really AIDPH's target audience, and we don't provide clinical services. We really invest in research and educational programming. So I was thinking, outside of just direct clinical services, how could AIDPH make a more authentic investment in this area? And who needs to be making that investment with us?
Really helpful.
So before we go into the breakout rooms, again, kind of, you're all seeing how the sausage is made here. So we've just been informed that our didactic presenter will not be able to make it today. So Annalise, that said, would you like to do those slides first as additional context, and then maybe the group discussion will be better informed?
Yes, let's do that.
Rolling with the punches here at AIDPH.
Okay, thank you everyone for just helping us through this formatting and thinking through the lived experience of LGBTQ plus people. Again, I am speaking from someone else's perspective. I do not have this lived experience. I am not LGBTQ identified, but I will say I work very closely with an LGBTQ community. I'm a board member of Equality Texas, which is the largest LGBTQ advocacy organization in the state of Texas, which is one of the largest states in the nation. I'm sure you guys know that. I am also, I have 2 LGBTQ identified children, and spend a lot of my time advocating for this community. So while I don't have this lived experience, I will share that I am an advocate, and it really is important work for me personally and professionally to ensure that LGBTQ plus people have inherent dignity and worth, and that their rights and patient experience are honored through LGBTQ appropriate oral health. So based on just my personal perspective, I'm going to do my best to talk through the subject today about honoring the lived experience of LGBTQ plus people as it relates to FQHCs. And again, we'll go into group discussion later, but maybe just keep those questions in mind as we go through the slides today. Next slide, please. And we can skip that one. Okay, so our objectives today will be to evaluate the social influence of oral health related to the LGBTQ plus community. Secondly, we are going to look at successful models of care and promising practices for LGBTQ plus health centers. And then lastly, we'll think about ways to apply inclusive and affirming practices in oral health care as a part of whole person health. Thanks, Jasmine. Okay, so let's talk a little bit about oral health and the LGBTQ plus community. So as a whole, LGBTQ plus people as a community, they tend to be less financially secure, have fewer familial connections, and struggle with accessing resources for a few different reasons, mostly through discrimination and stigmatization, and how even now more than ever, those lived experiences come into play. There are a lot of social determinants because of structural inequity that LGBTQ plus people experience. So As a result of that, we know that when a patient comes into the chair, into a health center, that they are not just struggling perhaps with oral health care, but really with an entire lived experience that can be part of discrimination and stigma. Providers often overestimate their knowledge regarding LGBTQ plus health, and that is probably for a few different reasons too. Number one, I think LGBTQ plus people, there is a lot of terminology changes. There is a lot of evolving healthcare practices. There are evolving best practices. As we put more focus, more investment, more involvement in this community, we learn more, and that's a good thing. But at the same time, if there is more knowledge available to us as oral health professionals, then that means that the onus of learning more and investing more should be on us too. And so sometimes there can be an overestimate or just a lack of knowledge regarding LGBTQ plus health as it relates to oral health, and then just in totality as lived experience and whole person health. So in this recent survey, almost 80% of primary care providers stated that they were comfortable treating LGBTQ plus patients. And I can say that AIDPH in 2020 put out a similar survey, not to primary care providers, but to oral health providers and sort of the oral health professional community. And we asked very similar questions about comfort level, satisfaction, and resources around LGBTQ oral health specifically. And we had very similar results to that survey, and that providers felt like they were not well informed. Providers felt like they wanted more resources, and also providers felt comfortable in some senses, meaning they wanted to treat these patients. They did not want to discriminate against these patients, but they didn't have the resources available to do that. Next slide. Recent research from Kaiser suggests that the community is more likely to suffer chronic disease conditions, have higher prevalence and onset of disabilities compared to the heterosexual or non-LGBTQ plus community. And that's probably for a few different reasons. LGBTQ plus people, along with BIPOC people, along with rural people, have experienced historical exclusion from the healthcare system. So many marginalized communities have just not been able to access structurally the level of care that they need to. And because of that, there is a higher prevalence of chronic disease conditions and a higher burden of disease and disability because of that structural inequity. We also know that, again, because of lack of access to care, that the HIV/AIDS epidemic, which is still ongoing, although not talked about as much as it has been maybe in the 80s and 90s. We know that this community experiences higher rates of HIV/AIDS, mental illness, substance abuse, sexual and physical violence, again, linking back not to that individual, but the structures and systems in place around them that can lead to these high prevalence of disease and disability. And I've already alluded to gaps in coverage. We know that LGBTQ plus people have higher rates of unemployment, again, stigma, discrimination. And so when you have a high rate of unemployment, that means that there's gaps in your coverage and your health insurance coverage. We understand that due to stigma and discrimination, that LGBTQ plus people may not want to go see a healthcare provider, and they may be fearing poor treatment from healthcare providers. And so it really does mean that we as an oral health professional community should be investing in education and authentic cultural competency in this area. So thinking through this a little bit more, we know that that this issue can be complicated or exacerbated when an LGBTQ plus person has a higher prevalence or risk of having a chronic disease condition. And then on top of that, have higher structural inequity, have higher displacement and more barriers. We know that then we sort of have this chain reaction of not seeking out care and then having higher disease burden or poorer outcomes as a result of that. So stigma in oral health care in particular is a topic that we should, be supporting and thinking through as oral health professionals and educators. So LGBTQ plus people often report that there is a disparate connection here with the name that is authentic to them, the pronouns that are authentic to them. And then when they walk into an office, whether or not those things are used on their forms, whether or not the patient care staff is informed of how to approach those issues. We also know it's harder for them to access resources. Again, thinking through whole person health, it's not just what happens in the chair, it's every step of the experience to get there, whether or not that person walks into a dental office and may have experienced stigma discrimination prior to coming to you that day, may have been misgendered that day, et cetera, and thinking through the entire totality of that patient experience and social support. For transgender, genderqueer, and HIV positive patients, it can be difficult to afford medications. And we also know that some of those medications have oral manifestations and implications associated with that. And I've already talked about this, dead naming, misgendering. It's often not deliberate, but because we as an oral health community may not be educating ourselves like we should, it does impact the patient care process. I know personally, whenever I take my children to an oral health care professional, I had a recent experience around that where they were misgendered the entire time, where I was not given the opportunity to indicate authentic pronouns, where I was not given the opportunity to indicate on the forms how to address my children and make an inclusive environment. And so what that boils down to is me as the advocate or the patient themselves having to then teach the provider. And that's exhausting. It's mentally and emotionally draining to have to walk into a space and say, okay, these are all the things that you've done wrong. How can I do this to have a better patient care experience? It makes you not want to go back to that place. And so really, when we're thinking through ways to invoke a trauma-informed approach, a lot of that has to be done on the front end through effective self-education. Next slide. So then thinking through successful models for LGBTQ plus health and where you can go to educate yourself, I love to talk about Fenway Health. They actually have an I think it's called the LGBT Health Education Center. So if you just Google Fenway Health and LGBT education, they have a phenomenal repository of educational materials, videos, they have scripts, they actually have modeled patient interactions where, you see a provider talking to a patient for all different types of healthcare subjects. And that's the best place to start. I also just want to say it may feel silly, but practicing aloud how to help a patient, how to walk through an interaction can be really helpful to just reinforce some of these practices. So they're definitely a model of success. Organizations must be prepared to offer resources and have community contacts who work in this population. That means that you have LGBTQ identified people working for your organization, working as patient advocates, and teaching your organization what best practices are. So ensuring that you have the right people at the table leading those efforts. You also have to have internal policies in place that educate and train your staff. I always recommend just an audit. Again, an LGBTQ identified person should be sort of leading that space and talking through the places where you could do better, but just doing a physical facility audit too. Are your bathrooms gender neutral? Are there spaces where you can create a more inclusive and welcoming environment? And then the same policies that encourage continuity of care in other populations can also be successful in an LGBTQ population. And there's some examples here. And I would just offer that again, a trauma-informed approach, which is one that we're really moving through as part of integrated whole person health, should be applied in every healthcare setting, but also in an LGBTQ population. And then lastly, legal clinics, name change process workshops, other social benefits can support this community. I know, thinking through last year, whenever we did a workshop on transgender oral health, there was a dentist, Michael Farmer, who works in Kentucky. I think I may have gotten the state wrong, but he talks about how, as part of his private clinical practice, that he goes to events in the community all the time. He's not LGBTQ identified, but he desires to really support this community. So whenever there are events around name changes, he'll come and say, you can also come to my practice. I'm an inclusive and affirming provider. So these are ways that you can signal support for the broader community, and ensure that you're really meeting the needs of the patients where they're at. Next slide. I think that's the last one. Oh, it's not the last one. Sorry about that. So this is the last one. Some more opportunities for you to really engage in effective oral health care for the LGBTQ community, reaching out to your community, and willing to act as a referral location. Houston Equality Network is a great example of this. They actually have a constellation of dentists in the Houston area who are affirming, welcoming, inclusive, and really can signal to the broader community that they're here to meet their needs and are equipped to do so. We talked about this a little bit before, finding staff that are trained in a gender affirming process and can honor names, pronouns, all of that very authentically and seamlessly for the patient from start to finish through the visit. Talking through your patients and really thinking through their lived experience and the totality of their healthcare needs, not just about what's happening in their mouth, but how, as a provider, you can support that through a whole person health approach. And then just, being a human being, being flexible with appointment times, understanding late patients, that's actually all part of a trauma-informed approach. It's understanding that these things happen as part of patient healthcare and being able to meet the needs of your patients as they walk in. So Stacey, I'm going to hand it back to you.
Thank you, Annalise. So I want to share, we have one question that came into me directly in the chat box, and that was whether we can access the resources mentioned from Fenway Health.
You can. So they are all free on this repository. They have YouTube videos. They also have webinars so you can watch on demand. I know that Fenway Health also has a couple of echoes themselves. So while ours is focused on rural health, they actually have a couple of LGBTQ echoes that are not specific to oral health, but I'm sure all of those things could be easily used within an oral health care professional setting.
Great. Any other questions for Annalise? Or any reactions to the information that she shared? Anything that surprised you? Anything that really reinforced some things you were already thinking? Anything in there that you think is actionable for you and your organization? Okay, well, why don't we then, I don't know if it's forward or backward at this point, but go to the slides with the case questions that we had shared earlier for the group discussion. And I'm wondering, so it looks like we have about 20 participants who are not staff. So I think maybe we'll just go into 2 breakouts, unless anyone objects to that. Okay. And Annalise, could you again paste these questions into the chat so that they're visible to everyone? So we're going to go into breakout rooms. Actually, half the group is going to be put in a breakout room, and then the other half will just stay in this main room as their breakout room. And the questions are, where are the gaps in non-clinical programs and services supporting LGBTQ plus rural oral health? What research should we invest in for this community to address the gaps? And who should AIDPH be partnering with to design programs and research in this area? So we're going to go into these groups for 10 minutes, and then we'll see where we are. And we'll plan to come back after the 10 to share some highlights of the conversation. So Annalise or Jasmine, if you could send us there now, please.
everyone. So I think we have joined the rooms, and I'm actually going to bring Stacy Chazen back. I clicked on her name by accident. So I think Stacy's going to continue to facilitate the discussion, but I'd love to hear just initial reactions, thoughts, and feedback here. Based on the conversation, where do we want to start with question number 1 around gaps? What do we think is missing, and where do we feel like we could create places to fill those gaps?
Hi, my name is Christine Edwards. I teach at USC, University of Southern California, Herman Ostrow School of Dentistry, and I teach partially this content as well as ethics and other topics. I will tell you that there is no focus for us at this point on the rural oral health experience. We do content. I can't say it's a quantity wise, it's huge. It's not. We do several sessions regarding LGBTQ plus for our dental students, first year, and then repeat it again in their third year. We do have a large transgender patient population, and we seem to be attracting more because of our location and our relationships within Los Angeles. So I really don't have anything to contribute regarding oral health. I can see that I need to beef up my content for them to be thinking of the experience outside of an urban setting. So that's kind of the message that I'm getting.
Yeah, and this is Deanne Richardson, and I'm in New York at the State Health Department. And I was just, I'm trying to get my video on here.
There you go.
Okay. I was just wondering, and I'm sorry, I'm also trying to inhale a little bit of a wrap for lunch. I was also just in the same vein as Christine mentioned, just trying to figure out in my head what would be the differences between urban and rural, because most of, I guess, what we encounter is more in an urban or metropolitan type setting. So is there any, are there any indications of a difference in the needs or the gaps in a rural community, other than, you know, the issues that might be similar for other disenfranchised populations, you know, like access to care and the social determinants of health? So that's kind of, I had more of a question than you know, a response. I certainly understand in rural communities that are more closely knit, smaller populations, where, you know, where some of the social networking and the social and the relationships within communities might make it even more difficult for the LGBTQIA plus community to seek services. So that was the only other thing. So certainly providers in those communities need, I think, probably training and education on how to provide adequate services for them. So I know you said non-clinical programs and services. From a state health department perspective, I think you mentioned it also. If I think Annalise is still in this group. Just looking at your databases and ensuring that you have appropriate demographic information so that you can have patients self-identify correctly. The health department is, and many health departments are in the process of doing that now, making sure that even in all of the data that we collect, making sure that we have the appropriate categories of data that will identify, you know, all populations that include LGBTQIA plus populations. I know the behavioral risk factor surveillance survey has done a great effort in making that survey analysis more inclusive from a population-based perspective. So those were just some of my initial thoughts.
Maybe Zil, do you want to go?
Yeah, I can sort of step into the rural hat here for everyone. Hi, my name is Zil. I'm with the National Rural Health Association, and I'd like to thank Annalise for dropping our LGBTQ policy brief earlier on in this conversation. One of the couple of things I wanted to touch on was one, from the rural perspective, we want to ensure that, like, from an LGBTQ perspective, they face a lot of the similar struggles that their neighbors in the urban or suburban populations will struggle with. The more of the divide that we would be looking at is both in the data sets that we are often collecting from individuals who will take samples of data, but will often forget about the demographic diversity that will come with those. So when you're looking for race, gender, LGBTQ identifier, they will often exclude large portions of rural America. And that leads to really big stopgaps in data collection, as well as then policy that comes through with that. So that's one of the bigger non-clinical services that we need to help support in that rural LGBTQIA space. The second thing is I wanted to touch on was maybe even kind of backing off of Diane's questions that some of what she had there, is that the general care in rural communities may not be lesser than those in their urban communities, but what happens is in those specialty programs are often either disregarded because of the sheer amount of time that it would take to get to and from certain places. And so when we talk about kind of transitioning into Q2, the second question is investing in those communities and saying, how can we integrate oral health into primary care? And while we're doing that, how can we address ensuring that those medical practices are safe spaces for our friends in the LGBTQIA space? And what NRHA and some of the different policy positions that we have is saying that although people are facing similar challenges when it comes to coming out to their communities and to their friends and family, ensuring that places with medical practitioners are safe, making sure that those are not only welcoming and accepting spaces. So collecting structural data is sort of that first component, but then saying how we can invest in the community is ensuring that there's health management systems out there and making sure that they are notably identifiable places for safe spaces in a community of anything of like 5 to 10,000 people or less, saying, well, maybe I feel like there's no one around here that would understand me, but there's definitely people in the community that will support you and feel like you have a foundational block. That's just some rural and LGBTQ intersection that we hope that NRHA can help at least talk about or bridge some divides with.
Great. Sherry, you have your hand up. Sherry, you're muted if you're trying to speak.
I'm sorry. Yeah, I was just looking at the clock. I didn't know if our 10 minutes was up, if we have to go back, or if
I think we can keep going for a few minutes. I'm going to check in with, so go ahead.
Yeah. So I'm a dental hygienist. I'm located in Maine, very, very rural. I'm also the program manager for the Maine CDC school oral health program. And you know what we do is we go to the public school setting, we screen students, we screen their teeth, we apply fluoride varnish. And something that I have found very interesting this past year is with the number of transgender students we were seeing, they don't want to be seen. They don't want to be looked at. They want to hide under their hood. They want to be at the end of the line. They don't want to share any more than what is asked of them. And what I've been trying to do is break that ice. So number one, I revised our consent forms that are sent home at the beginning of the school year to include on the consent form your student's name and their preferred name. So if I have a Susan that prefers to be called William, I want to call that individual William. I don't want to say, Susan, you know, you're next, come on down, when they don't identify as Susan. The other part of the consent form that I changed is we had gender on there, but I also put sex at birth. And I think it's important for, especially as we progress, you know, with the acceptance of the LGBTQ plus, I think it's important for people to know that difference. And I don't think it's being voiced quite enough. So like I said, I revised the consent form halfway through the year when I realized I was calling individuals not by their preferred name, but by their legal name. And the form did not identify what their preferred gender was. So I added those to the consent form. I'm curious to see how it's going to go over this next school year, but I think we need to find a way to break that barrier, break the ice, where we can engage these students that really don't want to engage, but we can engage them in the activity that we're doing. One of the things I thought I would come up with is on my name tag, I added she, her onto it. So it says, you know, my name is Miss Sherry and I use she, her for the pronouns. But yeah, I'm open to learning more. That's why I'm here. I just wanted to share that a little bit with this group.
Thank you. Any other comments before we fly back through cyberspace? Or the others, I guess, fly back through cyberspace and join us.
I just have a follow-up for Sherry and just asking, did you start in the middle of that semester starting with those questions, and was that sort of data collection, did they feel scared to like indicate what they were on those forms? Because I know you said about hiding, standing in the back, was that something you encountered often, or was it more of they felt more accepted in that way?
So the forms are sent out at the beginning of the school year, and the parents fill out the forms, not the student. It's a consent to be seen, to be screened, and to have a fluoride varnish application done. And like I said, I have not sent those revised forms out. I will this coming school year, but I started to revise it. I think it was December. I worked with a social worker who specializes in the LGBTQ plus community, and you know, just kind of went by his recommendations on what I should do with that consent form. So yeah, I don't know how it's going to play out. I'm hoping it's going to be a little bit more inviting, and that we're just not throwing individuals off by calling them their legal name and using that preferred name right from the get-go, you know, just to embrace it a little bit more.
I wish you good luck and hope that it goes over really well.
Thank you.
I was just going to add, when children are involved and they're, you know, of course, under the guardianship, or, you know, they have caregivers and are not able to consent for themselves, that often brings another layer to the challenge if the parent is not in support of the child's wishes. If, you know, there, you know, has not been, you know, any health or physical changes that have been, you know, done by a medical professional. There has not been any formal changes to a person's physical, there hasn't been any physical changes to a person's body. So I think I remember going to a webinar or something about that. So that brings in another layer if the parent is not in agreement with the child's wishes about their identity. more or less is the point I'm making.
So I see we had everyone back. I hope, sorry for the confusion. I was flying back and forth a little bit myself. I know that in the main room, there was great engaged discussion, and I wondered if folks from either room would like to share out any highlights.
Somebody from the other room we're moved from, I don't remember what their name was, but we were talking about that last question, and I had said something around the fact that like I think we should be partnering, like the AIDPH should be partnering with grassroots movements and organizations that know like their community best. And then somebody was saying something, and it was along the lines of we should be doing that because we shouldn't be treating every community just because they share that identity as the same. Because you know what they need, like for example in Texas, isn't what they need here in Arizona, you know. And so I don't remember what your name was, but you were making a point and I just wanted to hear it.
That was me. But yes, that's something that I also have a master's in public health. So that's something that a lot of the things that I remember learning, like doing like a community-based participatory research approach or community-oriented primary care, that it's extremely important when you do any of those programs to have community involvement and representation from the locals, because you don't want to helicopter in and be like, I'm going to fix things for you and assume that we know their lived experience. So and it's also kind of insulting to say like, I'm doing this for you, and they're like, well, maybe we don't want that or need that. You're making a lot of assumptions. So that was my point.
Yeah, because I agree like 100% is I was an MPH too. So I was definitely thinking community-based participatory research too. But I know here, like, even though, for example, like I am a queer person, it doesn't necessarily mean I know exactly what everyone here needs, because I have other identities too. So like my needs here just are going to be completely different. And also like as an academic, as a person who works as like in administration for like a community health center, I'm not gonna lie, like I might be a little out of touch with what people need. You know what I mean? Just by virtue of the position I'm in. So even though like I am a member of that community, I still need to be working with other group members to identify like what exactly they need. Because I still don't want to come in being like, hey, we're all the same. I know what you need. So it's like even avoiding that too, even if you are part of the in group. So I was thinking that as well. Thank you, Catherine.
Any other conversations folks want to finish up, or anything that came up in your room that you'd love the folks in the other room to know about?
One note that I really appreciated, it was kind of a gap that was seen, and then also a partner for potential research or programs was working with dental schools or students in professional training for dentistry, kind of working upstream to work with professionals in training. That way when they're done with their training and they're on into practice, you know, what they've learned they can take into practice, but also share it with you know, others that they're working with in a really authentic way. So education in dental schools and for oral health care professionals, I think it's a really important point that someone made.
I'm sorry, y'all, I tend to talk a lot, but I was gonna say I completely agree with you. Even with like residency programs, because where I work, we also work with AT Stills with their residents. And so one of the things that we do is making sure that their residents are able to get some time with our dental public health programs and help with kids, work with those patients that are more likely to be underinsured or uninsured. And so having them work directly with those patients gives them that perspective. And also if they move on to work at any other clinic, the information that we've given them, they can take to other places. And so some of them have been able to incorporate like some of the work we do with a program where we go into our pediatric clinics and we give them free screenings and free services. Like them going on to incorporate that at other centers, that's I think what our ultimate goal is in public health and education, is being able to get them the experience and hope that they take it somewhere else. So I think, yeah, getting those like budding professionals, that's the best place to hit.
Thank you for that. And I just want to reflect on how wonderfully engaged and engaging this discussion has been, despite all the shifts and rolling with the punches we've had to do on today's call. Thank you all for showing up as your best selves and really embracing the direction we went in today. I know a couple folks asked, we will be sharing the slides and we will be posting the recording. Jasmine, could you take us back to the closeout slide so we can go over next steps, please? So I'll just start by saying, oh, here we go. Okay, next steps. CEUs are available for today's session. As we always do, we'll send an evaluation and request form following today's call so you can qualify for those. We'll also be sharing strategic recommendations from today's session on the website in the coming weeks. Our next Rural Oral Health Echo Session topic will take place on July 28th at 1 o'clock Eastern. It will be personalized and predictive care. And if anyone is interested in presenting a case, whether on that topic or another, please reach out. Next slide. And as a reminder, you can earn a Rural Oral Health Certificate from AIDPH by participating in 8 of these sessions and completing the competency evaluations. So that is all we have for you today. We thank everyone for joining us. I see in the chat, someone asked, is there a listserv for this organization? And Annalise shared, anyone who registered will automatically be added to that. Christine is asking, she can't locate the resources for Fenway Health. Yes, we will send out a link to that in the follow-up materials. And thanks everyone again. Enjoy the rest of your, I think it's Tuesday. Is it Tuesday? Enjoy that day. Enjoy the rest of it. Thanks everyone. Bye-bye.
Thanks, bye.